Bismillah ar-Rahman ar-Rahim. I start with the name of Allah, the Lord of Mercy, the Giver of Mercy. I am Dr. Awan, the consultant physician, and I'm currently working in UK. Uh, Today, I'll be discussing about the status epilepticus, specifically about the management and the challenges about the diagnosis of status epilepticus. So we start with the learning objectives or the definitions of epilepsy, status epilepticus, and the subclinical status epilepticus. And we'll discuss in a bit more detail about the management of the status epilepticus. So we'll start with the real life case. This 72 years old female was admitted to the AMU with confusion. Clinical examination was otherwise unremarkable, except for the very low GCS, and news was 0. White cell was 6.6. ABG was suggestive of type 2 respiratory failure, although there was no history of COPD. ECG showed fast AF. CT head was normal, didn't show any infarct or bleed. And she was started on acyclovir, meropenem, and phenytoin provisionally. Later in the day, jerky movements of the arms were observed, and this was treated with lorazepam. Urgent EEG and LP were requested. Fortunately, EEG was done after a couple of hours, although it's quite difficult to do the EEG urgently, and sometimes there's delay of days to get the EEG. But fortunately, in this patient, the EEG was done on the same day after a couple of hours. And later in the evening, we received a phone call from the neurologist, and they had looked at the EEG, and this was suggestive of partial subclinical status epilepticus. So the LP was postponed, and she was switched over to levetiracetam intravenously, and antibiotics were continued for 10 days. With treatment, confusion improved, and she was discharged after 10 days on oral levetiracetam. So the definitions would, a couple of definitions before we go for the management. The seizure refers to the electroclinical events that the neurons naturally they are very coordinated conversation with each other. But when some group of the neurons start talking to each other suddenly, that results in seizure. And epilepsy, by definition, indicates a tendency for recurrent seizure. So the one seizure or one clinical event because of the electrical activity in the brain, and epilepsy is 2 or more than 2 seizures. And by definition, that is an epileptic. This is an epilepsy. Differential diagnosis is quite wide for the epilepsy because that totally depends on the clinical observation and the description by the witnesses. The thing we'll need to consider in the differential diagnosis are syncope, specifically when this is accompanied by the convulsive movements, hypoglycemia, cardiac arrhythmias, migraine, movement disorder, psychiatric issues, and narcolepsy. So I'll not go into the details of differential diagnosis because we'll be focusing on the management today. And the seizure classification, the focal and focal generalized, generalized from the beginning, and the patient with unknown onset. And the status epilepticus is by definition, seizure is continuous for more than 5 minutes with prominent, usually bilateral motor symptoms. And non-convulsive status epilepticus is under more than 10 to 15 minutes of sustained seizure activity without prominent motor symptoms. The generalized absence seizures, focal symptoms, or impaired consciousness, these are all can lead to non-convulsive status epilepticus, and this is quite challenging to diagnose. So delay in the treatment can result in the long-term consequences, the bodily injury and so many other neurological problems. And the delay for the tonic-clonic seizure more than 5 minutes is likely prolonged activity, and the long-term consequences are likely if the seizure is more than 30 minutes. In the status epilepticus with impairment of consciousness, so it's really a serious thing, and that can result in very serious consequences if the seizures are allowed to prolong. And absistent status epilepticus, usually if they're more than 10 minutes, they're likely to have a prolonged seizure activity. Etiology, 50% are symptomatic, 30% are cryptogenic or idiopathic, we don't know. So what is the reason for that? And 3 to 25% have a history of seizures, and 2 to 15% are due to progressive neurological illness, and 50% of patients have no history of seizures in the past. Drugs, especially the withdrawal of the drugs, is important precipitating factor, and alcohol, benzodiazepine, barbiturates, and cocaine should specifically ask for the intake of these drugs in last few days, and some of the medication can cause seizure as a side effect, like imipenem and INH. Systemic effects of prolonged seizures are cardiac arrhythmia, hypoxia, pulmonary edema, aspiration, and rhabdomyolysis. And now we come to our main topic, that is the treatment. So the treatment must start within 5 minutes of arrival in the hospital. Earlier the treatment, the better the outcome. So the beginning of the treatment, the start of the treatment should not be delayed for want of getting investigation. And this the start of the treatment prevents neurological injury and can prevent refractory status epilepticus. And 50% of these patients will respond to the first agent anti-epileptic treatment. So the treatment must start within 5 minutes, and as usual, we start with the ABC, secure IV line, and check for vital signs. Give 5% dextrose and thiamine 100 milligram intravenously, irrespective of the blood sugar or irrespective of other problem. This is not going to harm, but if you can check the blood sugar initially, that will help. And avoid paralytics in the beginning. Monitor blood pressure, heart rate, and respiratory rate, and we can send appropriate serum tests. But this should not result. We should not wait for the results, and we'll start the treatment immediately. The immediate treatment for the seizure is to control the seizure, and the drugs which used are the lorazepam, diazepam, and midazolam. So these have got immediate effect. Lorazepam, the dose is 0.1 milligram per kg IV. That's a rate of 2 milligram per minute. The maximum is 4 milligram per dose. Diazepam, the dose is 0.2 milligram per kilogram. It can be given rectally or 0.1 milligram per kilogram IV. Maximum dose is 10 milligram, and maximum rate is 5 milligram per minute. Another addition to the immediate treatment for the seizure is the midazolam, and this can be given intramuscularly. We don't have to wait for IV access. So 0.2 milligram per kilogram intramuscularly, maximum at 10 milligram per dose, or the another preparation wise available is 0.2 milligram per kilogram intranasally, or 0.5 milligram per kilogram buccally. So the difference between diazepam and lorazepam is their duration of action. So lorazepam is preferred for longer duration of action. It's usually considered that the lorazepam is a short-acting drug, and then in the elderly wards, this is preferred to diazepam for short-term effect for for agitation or insomnia or any other condition when tranquilizers or benzodiazepine are needed. But although lorazepam has got the short half-life, but the diazepam has got is a water soluble, and this is the area of the distribution is much wider, and the duration of action for the diazepam, because of the water solubility and distribution into the blood and other parts of the body, is shorter than the lorazepam. So anti-seizure effects is for sorry. Anti-seizure effect for uh, uh, diazepam is starts from 0.25 or 0.25 hours to zero point 0.5 hours. That's 15 minutes to half an hour. But for the lorazepam, it lasts for 12 to 24 hours. So that's the reason it's a preferred drug, because you don't have to give repeated doses with lorazepam. But for diazepam, you might need repeated doses to control the seizure. So although the half-life for diazepam is 30 minutes, for lorazepam, because of extensive protein binding, is quite prolonged. It is 14 hours. And sedation with diazepam is around 15 minutes to half an hour, while lorazepam, it can cause sedation for several hours. So respiratory depression is occasional to both of these drugs. So that's really, at that time, is not the concern, but has to be careful when giving any of these drugs. So the lorazepam is preferred in terms of its duration of action, and it's because it's just need given once or twice, while diazepam might need repeated doses to control the seizure. So if the seizures are not controlled with either of lorazepam or diazepam, the next choice is the phenytoin, second line drug, or the kind of long action, if for the long term control of the seizure. The choice is between phenytoin and the phosphenityne. The phosphenityne is nowadays preferred because because of the low pH, and the pH is almost nearer to the body pH, while the phenytoin has got very high pH, and this can lead to the vasoconstriction and sometimes the limb ischemia. I'll show you the pictures of one of our patients who got phenytoin and develops this complication, unfortunately. So the rate for the phenytoin infusion is 50 milligram per minute, and IV infusion rate for phosphenityne is 150 milligram per minute. But the dose is from 20 milligram phenytoin or 20 milligram phenytoin equivalent of the phosphenityne. So it can be given either phosphenityne can be intramuscular IV, but the preferred route is the IV for all emergency situations. The route of administration for the phenytoin could be oral or IV, but again, in status, IV is the preferred route. And both of these drugs need ECG and blood pressure monitoring. So the dosage, the phosphenityne is 20 milligram phenytoin equivalent per kilogram IV. So the maximum rate is 150 milligram per minute, and the blood pressure and ECG monitoring during the infusion is mandatory. The phenytoin, again, the 20 milligram is easier to remember the dose. The maximum 50 milligram per minute. If still seizing, give 5 to 10 milligram phenytoin per kilogram IV after 15 minutes to 20 minutes. But if still no response, go to the next medication. So the diazepam or lorazepam, the preferably the lorazepam. The next is the phenytoin or the phosphenityne, preferably the phosphenityne. This is one of the patient, unfortunately, developed complication to the phenytoin, and as you can see, the limb problem, the swelling, ischemia, and all these things. This happened with the phenytoin, and then the phenytoin was recognized early, but still the phenytoin was switched over to the phosphenityne, but this he developed his complication progressed to the extent of desquamation and all this problem with the limb. Right. So if still the seizure continue, the next drug is IV Veproid, but it's never been studied in a status. Nowadays, the preferred drug, the very popular drug in the medical setting is IV Levetiracetam. That is 250 milligram IV BD. Maximum is 1.5 gram BD. So control the seizure. And then still, if you need something else, then IV phenobarbital, and still the dose is 20 milligram per kilo. But patient is usually intubated by this time. So if you think the seizures are not really controlled in the first or the second line drug, inform the ICU and critical care. So they are ready to accept the patient. So in the time frame, the first 5 minutes, diagnose and do the serum test and give dextrose 50 to 50 and the thiamine. In next 5 minutes, either of the midazolam, lorazepam, or diazepam. In next 10 minutes, and next 10 to 20 minutes is phosphenityne 20 milligram per kilo. And still, if the seizures are not controlled, in next 10 minutes is a phosphenityne 5 milligram, 5 to 10 milligram per kilo, half the dose, but then this can repeat after 10 to 15 minutes. Still, the seizure continue, then next step is the phenobarbital, and then intubation or atogenic chemo. Outcome, unfortunately, the 8 to 30% in adults as the mortality rate and morbidity with systemic complication, neurological complication can up to be 70%. And the poor prognostic factors, the duration of the seizure, the longer the duration, the worse is the prognosis. Delay in the treatment, if there has been any concern about diagnosis or there was something which hindered the treatment, and treatment was delayed, will have the adverse effects. Cause of the seizure, whether structure, metabolic, inflammatory, or the toxic, have got worse prognosis than the idiopathic seizures or idiopathic statics, and autoimmune encephalitis and extremes of the age have got the poor prognostic factors. Focal subclinical seizure and non-convulsive status epilepticus. So this is when you really don't have typical convulsive seizures. The therapy should not be delayed to obtain an EEG in clinically apparent status epilepticus. The patient has some seizure activity and drowsy, is not responding. Sometimes you try to open the eye, they'll not open the eye. You try to open the mouth, they clench the teeth and resist the movements. So that's most of this. When you don't have any other reason for these findings, so think of subclinical or non-convulsive status epilepticus. However, during treatment, the continuous EEG is typically a necessity to diagnose non-convulsive status epilepticus if really don't have any other clinical feature. So absence status epilepticus and temporal complex partial seizure status epilepticus, the patient might have history of all these things, and there be if just keep the diagnosis in your mind, and that will help in diagnosing these patients with the state of status epilepticus. So what can you advise to your patient? That advise is you take the medication regularly after the seizure, take seizure and bring a calendar to your apartment, discuss with your provider with the seizure plan, what to do for a seizure and when to go for A&E, and manage the triggers, the stress, sleep deprivation, alcohol, and the drugs. So epilepsy is a common neurological condition, but with the treatment, 60 to 70% do well, but 30 to 40% may have medication-resistant epilepsy, and they really are at risk of developing status epilepticus. The treatment goal is the seizure freedom using medication with minimal side effects, and remember that status epilepticus is an emergency. Subclinical status could be challenging to diagnose. Explore the possibility of non-tonic-clonic epilepsy in critically ill patients. Just keep this thing in mind when you think there's non-convulsive, the patient is in critical condition. We don't have any apparent diagnosis. Some people coming with the delirium, hypoactive delirium. So think of subclinical status epilepticus. So remember that the public as well as doctors need reminders and awareness programs for keeping the diagnosis of epilepsy and status epilepticus, especially the subclinical status epilepticus, in all these conditions. Remember that even after the treatment of the status epilepticus, if the patient is not regaining consciousness and persistent drowsiness or unresponsiveness, think of subclinical status epilepticus, because this can be the reason in more than 50% of patients recovering from status epilepticus from the generalized tonic-clonic status. And thank you very much. And for any question or feedback, this is my email, and that is my YouTube. You can find this lecture on the YouTube as well. Thank you. Thank you so much for that.